Thank you. Thanks everybody for coming today. I'll put the CME info at the half hour in the chat box, and I'll hand it over to the next person in line.
Hello, everyone, and thank you for being here. This is Jose Cucalon Calderon. I'm an associate professor of pediatrics here at UNR Med, as well as general pediatrician for the renowned Children's Hospital. And today I am happy to present and say that I am also a member for our State of Nevada's MSRGN team. MSRGN meaning Mountain States Regional Genetics Network, which is going to be the main topic of our talk today. The lecture is going, or this event is going to be Nevada Pediatric Genetic Resources for Professionals and Families. Our learning objectives are: the learners will understand that the role of the PCP in beginning the genetic evaluation, the role of medical home once a genetic diagnosis has been made, as well as what the PCP or pediatrician can do with families to use resources better, and what would constitute a positive interaction with families surrounding the topic of genetics based on their family's needs and perspectives. Now I'm going to introduce Jamie Stefanski, who is our MSRGN representative.
Thank you. I'm gonna head back to the beginning here. So I am the state team's coordinator for Mountain States Regional Genetics Network. Thanks for joining us today. We are supporting today's event and are funded by HRSA. So HRSA is supporting today's event through honorariums for the speakers. We are a network of 8 states: Montana, Wyoming, Nevada, Utah, Colorado, Arizona, New Mexico, and Texas. And as I said, we're funded by HRSA. And we are on a 4-year grant cycle from 2020 to 2024. We're part of a 7-region network. And so here's the map of our 7 different regions. There's also the National Coordinating Center and the National Genetics Education and Support Center. Our mission is to, as the 7 regions within the US, to provide family-centered support. So our mission is to improve access to quality genetic services for medically underserved populations. And today, the Nevada State team is organizing this as part of their state team project to increase genetic awareness. One of the projects that Mountain States has is genetic navigators. And Hannah here on the picture on the slide is the Nevada State genetic navigator. If you want to connect with her, you can scan the QR code here up on the right-hand corner. Here's a little bit about Hannah. She is a parent of a child with a genetic condition, so that's one of the requirements of the position. And as a genetic navigator, she has some training in communicating with families and professionals in helping to support through the genetic journey. So with that, she can help discuss next steps with a family who has concerns, for example, about red flags for genetics or ways that they can talk to their physician, provide resources to a family who has encountered a barrier to accessing genetic services, connect families who have received genetic diagnoses to support organizations, or meet with families who want to get more involved as an advocate in the genetic system. So she can be a resource for you or for your patients. So I'm going to hand it off to Jose to introduce our speakers today. And I just want to thank you all again for joining us today.
Thank you, Jamie. Let me see if it's allowing me to move it.
I don't think it's going to, since I have it shared, but I can move it for you.
All right, well, I appreciate that. Well, I am very happy to introduce our discussion panel. Dr. Eckert is very well known to all of us, and we are very happy to have her back today. Dr. Eckert is a UNR, used to be UNR based until a year ago, and was our clerkship, pediatric clerkship director, as well as one of our pediatric endocrinology specialists. Currently, she is doing she's doing further training in a genetics medicine fellowship over in UC Davis. Maria, thank you, Maria, for being here today, is a parent advocate who would like to share her experience of being able to not only talk about the good and the things that could have been better about being able to reach a genetic diagnosis with her family member, but also trying to give recommendations for us to be able to follow and to consider. And now I'm going to go ahead and ask both of them to start discussing. I'm going to set some talking points, or I'm going to go over some talking points, and then we'll continue the discussion. Next. So, give me 1 second. All right. Where are they? Because I cannot find them.
You're muted, Jamie.
Sorry, the talking points are the objectives. We don't have a slide for the talking points.
Got it. Yes, yes. I thank you. Thank you for that. So I would like to ask a question first to Dr. Eckert. So with over your experience, what can we as PCPs or become more aware of when having a child that we have genetic concerns about? How should we think about, which symptoms are going to be symptoms that we should be giving priority to, or what would be the more common forms of conditions that showing day-to-day practice that will require genetic testing as part of their management?
Sure, great question. So I actually have a PowerPoint, if I can share my slides. Thanks. Let's see. So, obviously the topic is broad. Can everybody see my slides okay? Yeah, okay. So obviously the topics, both of them actually are really broad. And so we're going to go from a 30,000-foot view today. There's a lot of information on my slides that we just don't have time to talk about. So I apologize for the extra information on there. I'm happy to share those slides. Okay. Let's see if I can, there we go. I have only one disclosure, and that is that I'm a shareholder in Invitae. Please don't take that as an endorsement or invest because I did, because it's not really valuable. Okay, so here are the learning objectives that I was given. So just a little bit of background. So 5% of live-born babies have a congenital abnormality attributable to a genetic cause. So looking at preconception, prenatal, postnatal history, as well as a really thorough physical exam are really the initial steps that we all need to do. Now, that's not always easy to get preconception information, or even prenatal for that matter. A dysmorphology exam, including good measurements, that takes a lot of time. There's also a lot of digital imaging apps that one can do to kind of help identify syndromes, but really nothing beats a good dysmorphology exam. Also, a 3-generation pedigree with photographs of the relatives also oftentimes is a really great help if you're trying to discern whether something is unusual or dysmorphic. And then directed laboratory and radiologic testing to aid in the diagnosis. And then after all of this is done, that's when really directed genetic testing may be recommended. And we'll talk about what some of those tests are and some of the indications. So the answer to your question, Jose, really, here are the top ones that I came up with. There's a lot of other ones as well. And I'm not going to read through all of these. But importantly, you know, if there's a single major, so what constitutes major? Well, you know, congenital heart disease outside of VSD or ASD, you know, something bigger like tetralogy or transposition, something like that. Oftentimes we will do genetic testing, or multiple major and or minor anomalies. Dysmorphic features, as we already talked about, and especially if they're accompanied by developmental delay or intellectual disability. Failure to thrive is such a broad topic, and so sometimes we end up doing genetic studies, but not necessarily always. Abnormal MRI findings, unusual growth patterns, significant hearing loss or deafness, and about 30 to 40% of congenital deafness is due to genetic reasons. Patients born to a parent with a known chromosomal abnormality, including rearrangements, or if you recognize or suspect a genetic syndrome. So unexplained cognitive delay or intellectual disability now is one of the more common things that we would do genetic testing for, as is autism. And then progressive muscle weakness. So those would be the top 10 or so, however many are there, that we would recommend genetic testing. However, there's a huge laundry list of other things that we now commonly test for, okay? And I won't go into all of those. So I've divided this into kind of more genetic, dysmorphology or developmental issues, and then metabolic disorders, and then mitochondrial, okay? Just to kind of give you some bullet points on when we really want to take a good hard look. And as I've been in this fellowship for 6 months, and with previous history as an endocrinologist, I think back now and think about some of the patients I've had and really wonder if they had more than what was at face value. And particularly various storage disorders and other inborn errors of metabolism that are more subtle. So not every child with a metabolic disorder presents in acute crisis with hyperammonemia and acidosis. Some of them can be subtle and over a long period of time. And so probably the best thing I can say, which is, I know, very vague, but if something doesn't feel right with whatever the diagnosis is, or the child is just not doing as well as he should be on the therapy, think twice. And think long and hard, is there some kind of metabolic or storage disorder that may be causing that? So to start with, newborn screen. So every state has a little bit different list of what is being screened, but keep in mind that the newborn screen is just that. It's a screen. It's not comprehensive. It doesn't cover many of the peroxisomal and lysosomal storage disorders. And we get false positives as well as false negatives. So it does not rule out an inborn error of metabolism by any stretch, okay? If you see symptoms that are out of keeping with the typical presentation, like severe septic shock with an RSV infection in an otherwise previously healthy or relatively healthy child, think about metabolic disorders, okay? Anything that doesn't respond to treatment, so intractable seizures, significant hepatosplenomegaly or acidosis, cyclic vomiting, persistent hypoglycemia, all of these things, and particularly rhabdomyolysis and unusual body odors, those most likely have a metabolic basis for them. Unexplained IUGR, congenital hypotonia. So I was just recently at a conference in Salt Lake City, and they had a great couple of talks about what is lurking in all of our clinics. And so this is all subspecialties, all general pediatrics, family medicine. They are out there. We're not seeing them all the time, and they can be so subtle. So here's just a couple of the examples that were given. and especially the ornithine transcarbamylase deficiency, OTC deficiency. So we oftentimes think about those patients presenting in acute crisis, and it's X-linked, so only in a male. There are different variations on that. And so just because it doesn't act 100% like what the book says, please don't exclude it. Okay. So again, other storage diseases like Pompe disease, Niemann-Pick disease, they can present in more subtle and longitudinal ways. With the mitochondrial disorders, this is a tough one because mitochondria is almost everywhere in our bodies. And so it can preferentially impact different organ systems. And so you may present with completely different symptoms in any given person. But the thing that I like to keep in mind is if you're seeing disordered metabolism in various organs and it doesn't seem to really jive, think about the mitochondria. Okay, we're getting better and better about diagnosing these from a molecular standpoint. And so really in the endocrine clinic, we've diagnosed several kids with mitochondrial disorders who might have initially presented with what looks like type 1 diabetes, but then they come back with cardiomyopathies or maybe ptosis or ophthalmoplegias. And it's only over time that you can actually piece it all together that they actually have a mitochondrial disorder. So again, so these progressive and maybe vague things, fatigue, developmental regression, or at least not advancement, disorder of multiple systems and poor growth. Those would be the top ones. And then all of these other various ones, including dementia at the bottom or neuropsychological changes. So confusion, disorientation, not losing the ability to learn or remember things. Those should all be key factors in considering a mitochondrial disorder. Okay, so when to consider testing. So this is a huge topic, not only when to consider, but then what do you order? And in doing a review for this talk, it became very clear that there's not really great outlining for when to do what. Okay, and it's an ever-changing landscape in terms of which molecular testing is actually indicated, but also there's huge insurance implications there as well. So again, 30,000-foot view here. I'm happy to talk offline or if we have time later about what are the indications for various testing modalities. So if you get abnormal prenatal testing for an aneuploidy, then generally you want to get a chromosome analysis after the baby's born, with the knowledge, though, too, that sometimes that can miss mosaicism. So all of these have potential misses, of course. So that's probably one of the more common things that we see. So a Turner's or Klinefelter's trisomy 21, that we then have to confirm after birth that they do or do not have that. If there are dysmorphic features that are consistent with known syndromes, then, perhaps a chromosome analysis, but there's also some FISH studies, methylation studies, and FISH and methylation have very unique times and syndromes that you want to use those. They're slowly becoming more passé as we have whole genome and whole exome. And even chromosomal microarray for some of these is starting to become passé. We'll talk a little bit about the pitfalls of doing microarrays in just a minute. So neurodevelopmental delays, cognitive impairment, autism spectrum. So this also comes up quite frequently for us and probably everybody in the audience today. So the general recommendation is, again, depending on insurance, but microarray and a Fragile X panel. And the 2021 guidelines from American Academy of Medical Genetics actually suggests that exome or genome sequencing is first or second tier for more than one congenital anomaly plus intellectual disability and developmental delays. But that's not all that practical, okay, just from a purely financial perspective. So system-specific disorders, all of these that I have written here. So gene panels, there's plenty of them. GeneDx, Invitae, there's all kinds of choices for doing gene panels. Also microarray and whole exome. So it's hard to just point at one and say, hey, for all complex heart disease, let's do X, because it has to really be individualized. And then there's single gene disorders where you can just order that one gene, which is going to reduce, but not completely eliminate, any variants of uncertain significance or secondary findings, et cetera, that may be difficult to know what to do with. Okay, so here's kind of a rundown. So chromosome analysis, we've done this forever. It's relatively cheap, relatively fast, but you might miss mosaicism. FISH, again, very specific indications for that, fast turnaround time. The gene panels, now we're starting to get into more money. So $100 to $2,000, just depends. And this is where the variants of uncertain significance come up. And for those of you who aren't experienced with that, what can happen is when you're looking at even a single gene, let alone a microarray or a whole exome, whole genome, all these other things might get picked up that are not really relevant to the disorder that you're testing for, and or even on the genes that may be relevant, they can come up with what says this is not pathogenic, it's not benign, it's something that we have never seen before, we are not associating it with the disorder that your patient has. And those can be difficult to interpret. So that is one of the pitfalls of all of the rest of the ones on this slide here, that we have to be able to explain those to patients, because unfortunately, sometimes a VUS will come up and it gets put into the chart as, oh, a VUS for cystic fibrosis, therefore the patient has cystic fibrosis. And then it becomes chart legend, okay? When that patient truly does not have, perhaps does not have cystic fibrosis, and certainly does not have a pathogenic variant that is causing that cystic fibrosis, okay? Again, this is true for all of the rest of these tests. So microarrays, the pitfalls of this. So not just the VUSs, but A, it's expensive. B, insurance companies don't necessarily pay for that. And informed consent beforehand is important to do, okay? It's necessary. So here's what you can pick up on a microarray. You'll show deletions, duplications, so copy number variants, okay? So it's good, but it certainly doesn't show everything like an exome or genome does. One of the key things, and this occurs not infrequently, is that you can see absence of heterozygosity, which implies consanguinity between the parents, okay? And sometimes that is not anticipated on the parent's part and can be a real big surprise. Therefore, the informed consent is really, really critical, okay? The other thing is overall for autism and intellectual disabilities, the diagnostic value is about 20 to 30%, okay? Another key is insurances may say, okay, you get one test. So you did the microarray, we're going to prevent you from doing any higher level testing. So we have to be careful with which test we choose, okay? Fortunately, whole exome and whole genome are getting cheaper and faster. Insurance kind of plus minus in terms of whether they will cover that. I can speak to Medi-Cal, and Medi-Cal actually, if they're on certain plans of that, they actually will cover this now for certain indications. Medicare does not, okay? So the thing with both of these last two is that very extensive informed consent is needed, written informed consent. And you have to talk about any secondary findings, opting in and out for those secondary findings, and those are primarily cancer, hyperlipidemia, and heart disease risks that may come up. And ideally, we do those last two using parental DNA as well. Okay, so kind of went through these. So the testing results, again, the big flag is a VUS, and you have to be careful not associating that with an actual pathologic phenotype. So the ordering provider must be able to perform the informed consent, counsel the patient and the family about the results, and then following up on that VUS and secondary findings is also imperative. In other words, so every year or so, they may re-up the information on a variant of uncertain significance. So it's important that we keep up on that, and because sometimes they do get labeled as pathogenic down the road, or a very clear cut, nope, this is benign, we don't have to worry about that. Okay, so following that up in the chart is important. Okay, so I'm sorry I blazed through that, and not to minimize the medical home. I think probably all of us at some point have participated in being the medical home. And certainly there's no limitations on which provider that should or could be. In genetics, particularly for metabolic disorder patients, we are definitely the medical home, and we handle all the subspecialist referrals to early intervention services, the regional centers that are here, giving families their resources and so on, making sure they get PT, OT, speech, and so on. It's very time consuming, as everybody probably well knows. This is communication between families, healthcare providers, schools, other physical therapists, OTs, et cetera, coming up with helping with 504 plans and the like, mental health coordination, equipment, dental care, respite care. All of these things are really part of being that medical home. But as I'm sure our family will relate to you later, very, very critical for getting all those things in place for what our patients need. And this extends, for us anyway here, it extends through adulthood. So we have many patients with PKU who were born before the newborn screen was even out. So they were not treated for several years, so have significant developmental delays. So our medical home continues completely outside of the juvenile ages. So it has been shown that coordinated care can result in decreased emergency department visits, hospitalizations, missed school days, fewer work days, missed improved family function, and reduced family stress. Patients will probably need to be seen more frequently in the office or their caregivers at a minimum. And some of this can be done by telephone or telemedicine. This creates some reimbursement issues, no doubt, just the time that is spent. And we could talk about this at another time, but there are ways around that, including increasing the visits, which also enables us to get to know the patient better and on a more frequent basis. If that patient is on CCS, at least in California, we have team conference calls about every 3 months on every given patient. And so that enables us to really everybody be on the same page. Okay, so here are some resources for you. These are all online resources. And if you have any questions about any of these resources, I'm happy to help with that as well. Again, my apologies for really whipping through that. Here are my references. Lots of these are actually pretty good reads.
Thank you, Dr. Eckert. Before we open up for questions at the end, I am going to ask our parent representative here today to share what she would be willing to share about what the diagnostic odyssey for her and her family member actually included, as well as to talk to us about what role the medical home had in her family members' care.
Are you ready for me now?
Yes, yes.
Okay. So, hi, my name is Mariah Spry. I have 3 kids. Hello. They're all here. Morgan's in the back over there. Avery's over there. I'm over there, and then Avery's over here. I'm Taylor. My husband's at work. So we have 3 kids. We have twins, Avery and Morgan, that are 18, and then Taylor is 15. And the journey for like a genetic diagnosis was pretty bumpy because the twins were born premature. And so a lot of the issues that we were dealing with were considered to be because of their prematurity. And then as things evolved, they got more complicated. I unexpectedly was pregnant with Taylor. And then while I was pregnant with Taylor, the twins, they were having some of the things that Dr. Eckert mentioned, like they were having really frequent illnesses. They were having a lot of developmental delays that couldn't be explained by their prematurity anymore. There were a bunch of GI issues. The GI stuff was the biggest for them. There were cardiac issues. There were lots of different systems involved. And we had been traveling back and forth to Cincinnati Children's Hospital because their first diagnosis was eosinophilic disorder, and the specialist was over there. So when all these different things started happening, he said, there's something else going on. So that's when he was alerted to kind of look into a more genetic cause. So the twins had muscle biopsies done. That was the first thing that was done because this was back in 2007. And then at that time, genetic testing by blood was still very, very new. So it came back positive for mitochondrial disease. And all we were told is that it was in the third, I forget what it's called. My mind is blank. And so they were having issues with like their muscles. They were tired all the time. They were fatigued walking, lots of issues. And then when Taylor was born, the GI issues were even bigger. There were a bunch of endocrine issues, a lot of low blood sugars, like they couldn't fast. We actually saw Dr. Eckert when she was an endocrinologist with Morgan. Morgan was diagnosed with cyclic vomiting syndrome. We've been through the ringer with geneticists. We ended up switching all of our care to Stanford because flying got too expensive. And we also got hooked up with a doctor at Stanford who deals a lot with mitochondrial disorders. And we've had the whole genome, the whole exome. We've had some of the smaller testings done. They have found all kinds of things that are kind of incidental. And every time that they run the DNA testing, it seems like they find new things because the testing gets more sophisticated. So yes, it's a lot of paperwork. We've had to sign a lot of waivers. We've had throughout all of this, since the twins were 2, we've had a fantastic pediatrician who has been able to do all the referrals he talked about. We've had things like, early intervention, respite. We've had, I can't even tell you, I think there's like 15 different specialists involved. That with the mitochondrial disease, a lot of it is unknown and their version is unknown. 2 of them were also recently diagnosed with myotonic dystrophy. And so I guess that's a whole new genetic thing that we get to look at. So yeah, it's very important. I think the biggest thing that has helped, I think, is having a pediatrician who understands and listens to me, listens to the kids. Another thing that I think is really important for all the doctors to know is that your front office, it helps tremendously when they know you also, because we've had, a handful of times if a doctor has a new front staff, they don't know you, they don't understand that, hey, at the time 2 of my kids had central lines. One of them, Taylor, has been on TPN for 13 years now. And so, when you have a kid on TPN and they're sick, it's a totally different situation than somebody without a central line. And so having a front staff who also knows the patients, I think, is a really big deal, because they have to be able to be the one to try to figure out how to squeeze you in, for an appointment, if they can. So yeah, it's very important.
Thank you very much for sharing your story and your family story, Mariah. That's some very good recommendations for us to consider as speaking as a general pediatrician myself. And I agree, enhancing communication and being able to connect with resources is what has allowed me to be able to deliver care in the best way possible with whatever limitations we do have in our state, because there are some. Some of them have been listed already on the chat if people want to read them. But encouraging communication and working together is definitely going to be a part of the key to the success of being able to help families.
And I think if there were resources also, back when the girls were first diagnosed, there really weren't resources that we were told about. The kids didn't fit in any of the standard boxes for resources. And so the more resources that pediatricians could provide to families, I think would be even better, because it's incredibly difficult having kids with complex medical needs. And in the beginning, you're kind of floundering, trying to figure out how to manage all of it yourself. And yeah, it's a lot. So I think if there's a way to help with the resources, that would be amazing.
Well, that is how this grand rounds begun, actually, as an open space to be able to talk about resources and what we can do to help pediatricians and primary care providers to be able to know what they have available, including MSRGN, which are doing a great work across the country.
Yeah.
All right, I'm going to open it up for questions from our guests. Please unmute yourselves and ask. That's going to be easier.
My kids also said that they're willing to take questions if people wanted to ask them questions. So they're here too.
I don't know some easy words.
Thank you, guys. That's awesome.
And you guys can come sit next.
Okay. So I'll just lean in.
All right. Let's see, I can see on the chat that we have a good bit of discussion about children that we have been able to identify need for genetics testing, and that difficulties that multiple people have when trying to be able to have that testing covered by insurance. I see that and I see that mostly the discussion is around Medicaid, and that Vicky, who is one of our team members for MSRGN, has already shared some of the resources we have. Yes, Dr. Rist.
Hello. Thanks so much, everybody, for talking with us today. For Mariah and the kids, I'm wondering specifically what types of resources have been most helpful for you, and what kind of information would you want from your pediatrician at different stages along the kids' development?
That's a tough question. Yeah, I think looking back, yeah, it's hard. If there was something that could kind of help families kind of figure out, okay, what do you need to have in place at home? Even as simple as, okay, you have a child with a central line now, so you have very different guidelines you have to follow when they're sick. We were lucky that we have a pediatrician who is able to filter in information from different specialists, because often I get stuck in the middle between different specialists. And so our pediatrician has been really good about being able to figure out, okay, well, how about we take this bit from this doctor and that from that doctor, and then we do this. And that makes sense for Taylor, because she needs that when she's sick.
I'm special.
Yeah, you're special. So I think it's almost like if there's like a map of, like what to expect when you're expecting, like that book that they give for people when they're pregnant, like something like that.
What to expect when
When you have a kid with or children with medical disorders or complications, just things that are different. It affects everything. I mean, I was a teacher, I had to quit because I had too many, I used all my sick days in like the first month of school. We have spent a ton of time in hospitals, knock on wood. We've not been admitted in a long time. But I
Thank you,
think
IDIG.
maybe, I don't know. I mean, the biggest resource, I think one of the biggest things is just taking the time to listen and show compassion and just talk to you like you're a person and not like you know more than the patient. And that's probably been the most helpful piece for me, is when the doctors come in and they talk to me like I'm a person instead
I
of.
listen to what you said.
Yeah, and when they listen to the kids too, and they want the kids' opinion, they want to know what the kids think. But my favorite doctors are always the ones that magically can incorporate the kids and me and my husband into the conversations. I mean, I've had doctors who just want to talk to the kids, and I think that's hard on the kids,
We
and
don't always
it's
know
not very
everything.
nice to me because they don't remember everything.
We're not very good at remembering medical terms. There's a
So
lot of fancy words, fancy names.
I know that's hard for doctors. I know their schedules are insane, but when those doctors do take the time to sit and talk to the patients, that's a really big help. That, and then like the resources, the thing with Medicaid, man, I didn't know about Medicaid for the longest time, and the hoops that you have to jump through to get Medicaid coverage is insane, and it takes a lot of effort to try to figure out that whole system. And just when we think we've figured it out, Morgan and Avery get kicked out of it in 2 months. And that's not fair.
But if I can add something, we continue having struggles with being able to have, especially public insurances cover for genetic testing, even the most basic ones.
Yeah.
And then that also gets complicated a little bit for us through the state, because I think we still have one genetic specialist that is cited out of Southern Nevada, but I am unsure what insurances she is actually seeing. I think that she's not seeing any public. I think she's only seeing some private. So most of the care when we put a referral, especially for Medicaid patients, has to go out to Utah at this time, because that's who has the Utah hospital system is the one that has the contract for most of the state programs. Before, it used to be closer to go to Stanford, and Stanford services were covered, which was nice, because they are great at communicating also with us on patient care. And before that, I know that Davis was also part of that web. But this is a continued challenge, and hopefully we will find a better way of doing that. And really appreciate all four of you collaborating today and talking to us, because that experience is valuable, and it mirrors with a lot of has a lot of similarities with some of the things that we're seeing on a day-to-day basis. Dr. Woodhull, yes.
Hi, yeah, thank you so much for the presentation today. This was great. My question is for Kathy or Jose or Vicki Ives, kind of in response to the Medicaid microarray testing. It's first-tier testing for a lot of what I'm looking at. I have never been successful getting Medicaid to pay for it, so I've kind of gone through some other channels with other types of tests, and again, that's not like recommended. So I'm just curious, like what if Vicki's post was that it is covered by Medicaid now, it seems like, because I've been unsuccessful as recently as like last week. So I'm not sure if maybe I might be doing something wrong, if you have any resources to try to get that covered by Nevada Medicaid.
Oh gosh, thank you for the question. And what we've been told, the Mountain States Regional Genetics Network was able to get a representative from Nevada Medicaid to attend one of our meetings, and they shared the resources that I put in the chat. They also shared that on the fee for service side, and this was last August, so August of 22, just in terms of the information. On the fee-for-service side of Medicaid, they do not require a prior authorization in order for chromosomal microarray analysis, but the MCOs may have a prior authorization requirement. But it really seemed to boil down to they work with a vendor on kind of the rejection and acceptance piece. And if there's a case that's been rejected, take that to Medicaid staff, to the Division of Healthcare Financing and Policy, and they can help on a rejection, because we've heard pretty uniformly difficulty in getting payment and getting rejections. But when we spoke with the Medicaid staff, they're like, here, it's in policy, it's covered. There's also routes if it's considered medically necessary under the early periodic screening and testing route in addition. So there does seem to be a bit of a disconnect, but I'm happy to connect you with specific persons at Medicaid. But they did stress that they can be most helpful if there's a specific case that's been rejected, that they can follow up with the vendor. And please correct me for the others that were at that presentation if there's anything you want to add or correct. But thank you for the question.
Thank you, Vicki, and thank you, Dr. Woodhull, for that. I have to say that my experience has been, like, I was present at that meeting as well, and I have reached out to the team on a couple of my patients over the last 2 or 3 months with actually good success and being able to discuss. So they were okay with us sharing the email of their office with providers. So we can probably do that as a follow-up email from the meeting. Of course, my experience ordering genetic testing on a day-to-day basis is a lot more frequent for children who have syndrome, have a new onset diagnosis of autism, which we're seeing very frequently, and it's going to be a little different than what you're probably ordering, Dr. Woodhull. But I have not received any denials for a microarray on any of my children with autism in the probably last year. Unexplained developmental cognitive delay has also been something that I have been able to use as a diagnosis, or cognitive delay itself as a diagnosis that has allowed for coverage for microarrays, as well as multiple congenital anomalies as a diagnostic code, if that helps.
Yeah, thank you.
I was just going to add to that, when necessary, you can, in your plea, you can always use the ACMG guidelines as part of that in terms of trying to get that paid for, for some of the things that Jose was just pointing out. So neurodevelopmental delays, intellectual disabilities, autism spectrum disorder, those are fairly commonplace and part of the ACMG guidelines. So you could use that. And then I had a question for Vicki. Do you know right now what the status is for whole exome or whole genome with Medicaid? Or whoever wants to take that. I don't want to put you on the spot, Vicki.
No, I'm unsure. So let me find out, and we can loop that in on the response, the follow-up after the call as well. So thank you for that question.
I have a question for you, Dr. Eckert. Do you know? So my understanding, or at least when I discussed with insurances about covering for whole exome sequencing in some patients, part of the reason that was given to us was the cost, of course.
Sure.
My understanding is that it continues to be proprietary technology, which is why it is so costly. That labs are not able to actually just make their own type of assays and stuff like that, and just like use it that way. Do you have any insight as to when that might be up? Because I would seeing previous technology for genetic testing and the way that it followed, like the way that what happened was that once it became a lot less expensive, it was better covered.
Yeah, so I mean, it's so quickly evolving, the whole scheme of molecular testing, that probably whole exome is going to be outdated in 2 or 3 years, quite frankly, because everybody's just going to go to whole genome. There's pitfalls with all of these tests, right? But we're getting faster and cheaper with whole genome and whole exome. Now, I don't think that every hospital in every town is ever going to be able to do this level of testing. It just doesn't make sense to do that because the machinery and expertise behind it and interpretation just is not available. So I think it'll always be a send out, but it's going to get cheaper and faster as we move forward. But, even now, I mean, whole genome isn't even the whole thing anymore. Now we're doing RNA and, there's just so many other things out there that I think that technology is just going to continue to evolve. So, I mean, even whole genomes, we can get back sometimes in 2 to 3 weeks. So similar to whole exome. So it is getting better. And the prices come down. It's still very, very expensive. No doubt about that. So hope that answers your question.
Absolutely. Thank you very much. All right. Any more questions, anybody?
One thing I just wanted to add to the Spry family too is, I don't know if the kids are still there, but I guess a comment and a question. So one of the most important things with any kind of chronic disorders is how are the patients themselves when they're younger and at diagnosis, how are they combined into the knowledge and their treatment plans, and how well did that go for you guys? And what can we do better as care teams to help with that transition?
Yeah, so we've always had all of our appointments with the kids. So like they've been privy to all the information all along. When they were little, a lot of it was over their heads. The information
Still a little bit over.
No, the information was tailored, more to them. But now that they're older, they're privy to all the information. The transition to like helping take care of themselves and sort of their own medical care, it's still me. There's some things that they are doing now, like as far as giving themselves their own medications, like the pills and stuff for Avery and Morgan, but not Taylor. Taylor's are IV stuff, so yeah,
Just a little bit.
yeah.
Well,
She did recently
a
learn
little
how to do
bit.
a dressing change, but as far as how could it have gone better? I don't know. I mean, I have friends who have kids with similar circumstances and both spectrums, like, where the parents haven't told the kids very much. And then the other side where the kids know maybe a little more than I think they should. And it's just kind of however each family operates. I think that the doctors can kind of take the lead from the parents as far as, how much they want to share or hear with the kids in the room. But I mean, we used to give our kids toys and they would just play on the floor while we talked with the doctors. Like
We didn't know what was going on.
We
had
didn't
no
send the
idea.
kids out. I mean, there were childlike people that would come in and say, do you want me to take the kids out? And we're like, no, they're fine. They can play. And they
We
would
had
just play with their
fun.
toys.
We played with toys.
So-
It was quite entertaining for me. I was just over there having a good time.
So yeah, I mean, they joke about it now because like when they were first diagnosed with the mitochondrial disease, we were told that they wouldn't see their teenage years, that they wouldn't survive. And there was so much that was unknown about that diagnosis when it was first made. We were just kind of, every symptom had a different specialist that we were seeing. And they weren't really working together, except for the pediatrician. We would always go back to the pediatrician to try to figure out, okay, well, what about that? And what about that? And the kids now will joke about it and say like, oh, I wasn't supposed to be alive by now. And they're doing well. They still have, a ton of things that they deal with on a regular basis, but overall, they are doing phenomenal compared to any expectations. And so, I mean, they're very aware of all of it. Our pediatrician has said that she will see them even as adults, which I'm super thankful for because I'm terrified of changing doctors.
Okay, thank you.
Yeah.
Well, with that, we don't have any further questions, we are going to thank everybody for connecting today and for Dr. Eckert and Maria, as well as your family. We really appreciate your time and your experience, and thank you for sharing that. That is so powerful and so important for us to be able to be aware of, and not only for that, to recognize and to act on it as well. The links and information for MSRGN has been shared in the chat. Please feel free to reach out to MSRGN as a team or to me if I am a little bit more approachable, and I am happy to connect with the team, as well as with other resources that we might have. Thank you, everybody. Thank you for your time, and hope you had a good lunch.
Thank you.
Thank you.
Thanks.
Thank you, everyone.
Thanks so
Great
much.
day.
Thank you.
Jamie, if that recording link goes to you, will you send it over to me?
Yes.
Thank you.
There you go. Now say bye-bye.